Hi everybody, I'm Dr. Nari Heshmati. I'm a board-certified OBGYN just north of Seattle in Everett, Washington. And today I'm back at Mukilteo Beach, beautiful little beach, and I'm going to talk to you about endometriosis. This is going to be our first GYN topic, and I had a radio interview locally for it, so I had to prep a lot of stuff, and I thought this would be a good segue into it. Endometriosis is a really common condition. So first we're going to talk about what is endometriosis. Then we're going to go through what are the symptoms, what are the treatments, and what kind of things can we expect. Well, endometriosis is when the glands from inside the uterus are present outside of the uterus. So inside the uterus you've got that lining that's going to grow and shed each month, and that's going to be what your menstrual cycle or bleeding is. Now when those glands are present outside the uterus, whether they're on the outside of the uterus, the ovaries, the pelvis, they can even be all the way distant to organs like the lungs. Now those endometrial glands that are outside, that endometriosis is going to respond to your body's natural estrogen each cycle. It's going to grow and it's going to bleed, and that's going to cause inflammation and scar tissue that's going to result in symptoms. Now the symptoms that most people have with endometriosis, so the classical presentation of endometriosis is somebody comes in and they say, you know what, I'm starting to have worsening and worsening pain with my menstrual cycle. It starts a couple days before and continues through my cycle. And again, that's the response of those glands outside the uterus growing and causing inflammation and pain. Now the other symptoms that people can show up with is people will come and say, I've got pain with intercourse, specifically with deep penetration, because there's an area, the posterior cul-de-sac, that's right behind the uterus that endometriosis sits in oftentimes and can cause scar tissue and things like that. Some patients will come in having pain with bowel movements, pain with urination, again because of where endometriosis can be. It can result in some infertility, it can result in some chronic pain. So those are kind of the classical symptoms people are going to see. Now the average age of diagnosis of endometriosis is about 30 to 40, but it presents much earlier. It's just oftentimes I think people didn't realize that these symptoms, or they weren't bad enough for them to seek treatment. Now 10% of all reproductive age women have endometriosis, so it's really common, but the presentation is highly variable. So some people have a lot of symptoms, some people have very little symptoms, and it sometimes has nothing to do with how much endometriosis is actually present in the pelvis. Now when you take a look at endometriosis, it is present in up to about 40% of infertility patients, and those with chronic pelvic pain or significant pain with their cycles, it's going to be more than half of them. So it can be really common in those people with symptoms of it. Now, when somebody comes to me, they say, can you do a test, a blood work, can we do something to check see if I have endometriosis? Well, endometriosis, because these can be little tiny areas inside the pelvis, they don't necessarily show up on imaging. So if you do a pelvic ultrasound like we often do, you're not going to see anything. The only time you're going to see signs of endometriosis is you might see an endometrium, or what's a big blood-filled cyst that can develop on the ovary in some people with endometriosis. On a physical exam, sometimes the uterus doesn't move as much as it should, or there's going to be tenderness at certain ligaments and things like that. There is a blood test, the CA-125, that we use for ovarian cancer, and it can be falsely elevated in endometriosis, but that's not a good test to do it for. So in general, we look at symptoms for endometriosis. And the management of endometriosis, because this really is a chronic, lifelong condition where we try to manage it as well as we can medically and minimize surgical intervention as much as we can. But the management of endometriosis is, NSAIDs, things like ibuprofen, things like that, and then hormonal. So we'll put somebody on birth control pills if they come in and they're having pain with their cycles and we suspect endometriosis, because the birth control pills are going to lower their natural estrogen, and the progesterone there is going to help shrink these endometriosis glands. Now there's other things other than birth controls. There's the Depo-Provera shot we can do, there's the IUD that secretes progesterone, but these are all kind of hormonal things. Now when you look at that, those hormonal methods are going to provide us pain relief. So this is quality of life. They're not necessarily going to improve infertility outcomes or other things like that. The reason that people with endometriosis can have infertility is a combination of the inflammatory markers there, and probably later in the course of it, it can damage and scar tubes and things like that. So that's really a combination of surgical management and reproductive fertility techniques, so things like IVF and things they can do. Now I throw out there, I've got plenty of patients with endometriosis who are pregnant, and pregnancy itself suppresses endometriosis, so don't think that you can't get pregnant. But that is something that comes up. In general, we manage people medically. We put them on something like birth control pills, and if that controls it, fantastic. We don't have to do anything beyond that, because the only way to actually determine if somebody has endometriosis is surgical. We have to go do a laparoscopy. Now, laparoscopy is basically where we make an incision, usually at the belly button, another one on the side, and another one usually on the other side, we fill the belly full of gas in the operating room, and we go look around. It's the same way they take out an appendix, a gallbladder. We do these all the time, but it is a surgery, so it carries some risk. But that's the only way to definitively tell if somebody has endometriosis. We basically go look around, and you can see the endometriosis. You can see these often powder burn looking like implants. Now, they have different appearances. Some are clear nodular. You can find adhesions and things like that. And you could biopsy them if you want to confirm them. You can burn the areas. You can take down scar tissue. You can do things like that. Now, oftentimes we go on to laparoscopy to identify endometriosis in people who fail initial medical management. Meaning, if you've got symptoms of endometriosis and you're on birth control pills and your symptoms are controlled, you really don't have to do anything more. Because although we can definitively identify endometriosis at the time of surgery and we can treat it, within 2 years the majority of people are going to have return of their pain. So really medical management has to start again after we identify endometriosis. So really, for me, laparoscopy and that surgical identification is in somebody who's failing our traditional therapies. We want to get more aggressive, and we just really want to confirm things. Now, there are even more aggressive medical therapies out there. So sometimes when we identify endometriosis and somebody's not having good pain relief with an IUD or birth control pills, we might try something like Depo-Lupron. That's a shot that basically shuts down all of your hormones. It temporarily induces a medical menopause. Your estrogen levels are going to fall. There are hot flashes and things like that. So there's some unpleasant side effects. But that's going to work really, really well for suppressing that endometriosis. And we might do that for 3 to 6 months just to try to get a handle on things so that we can then go back to birth control pills or something else from that standpoint. The entire goal, so when you look at the Reproductive Society, one of their committee opinions out there basically says that endometriosis is a chronic condition. The goal is medical management essentially for quality of life and trying to minimize surgical intervention. So that's the goal. We're trying to medically manage. We do laparoscopy to identify it when we have to. We try not to go back repeatedly if we can help it. And then ultimately, if all else fails, the definitive therapy for endometriosis is hysterectomy, either with or without the removal of the ovaries. And we try to really hold that off for people who have significant pain that we're just not controlling any other way. So, endometriosis is common. We don't actually know what causes it. We do think it comes from possibly retrograde menstruation, where when you have a menstrual cycle, you bleed back through your tubes, and maybe that carries the glands back. Now, 90% of women at any time can do that, so there's also a genetic component, so we don't 100% understand that. But those glands are outside the uterus, they flare up, they respond to hormones, they result in pain, infertility, and we can often manage it medically. And if we can't, we go on to surgical things and get kind of more aggressive if we need to. But again, it's common, it's treatable. So if you've got these symptoms, come in and talk to us, and we could probably come up with a plan that's going to work for you. Thanks a lot.